Hi, my name's Jackie Kraft. I am a neurointensivist at Emory University Hospital, and today we're going to be talking about death by neurologic criteria or brain death. I have no disclosures. Just to briefly review the history of death by neurologic criteria, it was first recognized that a patient had complete and irreversible loss of all brain function in 1959, and this was referred to as coma dépassé, and this was recognized in France. It wasn't until almost 10 years later that the first clinical definition was published by committees at Harvard and the 22nd World Medical Assembly with specific brain death criteria. It was not until almost 3 years later that the first country, Finland, recognized brain death as a legal form of death. And then the US followed almost 9 years later with the UDDA, stating that brain death was one of two forms of legally recognized death, and the other being a cardiac or circulatory death. Over time, there have been many different countries with different neurologic criteria and ways of determining death by neurologic criteria. And so in 2015, the World Brain Death Project sought to bring together experts in intensive care, pediatrics, neurology, neurosurgery, as well as critical care nursing to develop the minimum criteria across the globe for determining death by neurologic criteria. And that's really what we'll use to refer to today.
These are the two guidelines that the majority of the recommendations I will talk about today will come from.
Before we get started in going through the guidelines, I want to go over why is death by neurologic criteria really an issue and why are there so much conversations about it? Well, I think first of all, we see as we get better at taking care of patients, we have increasing patient complexity and acuity, which adds different complexities to the situation. We also see advancing therapies, which make determining death by neurologic criteria more difficult. So we see targeted temperature management, changing patients' metabolism, as well as their temperature, which can alter our brain death determination. We also see the use of things like ECMO, and so with increased guidance as to how can we determine brain death in someone who is on an ECMO circuit. We also see this variability in practices, which is one of the reasons why the Brain Death Project was started. And then, of course, it's unclear to me whether this is as much of an issue as it is for you as it is for us, but we see an increasing public distrust in kind of healthcare and the physician community at large. So wanting to make sure that we have a very strict criteria to probably make the most important diagnosis of our careers. And that is to say that someone is truly dead when they are and not miss this diagnosis. The other thing I want to go over before we get into the nitty-gritty of the guidelines is what are the most common errors or pitfalls that people make in brain death determination. So number one is failure to establish a cause. So you need to have an actual cause of why this patient is likely dead by neurologic criteria. If you have a normal CAT scan and no history that goes along with a patient being neurologically devastated, then you cannot just declare that patient brain dead. So that's kind of the most important one. Errors in clinical exam is number two. This is usually an issue with kind of not recognizing metabolic confounders. So a patient being very hypothermic, a patient with extreme uremia or hyperammonemia. These are things that we're going to go over. And then we talk about errors in apnea testing, making sure we have stringent criteria for how we're going to do apnea testing so we don't make errors. And lastly, issues with ancillary testing, when to use these, how do we, interpret these? Are there certain tests that are appropriate for certain patients and not others? And we'll go over some of this today. Prior to testing, we really want to go through a checklist and make sure we have everything set up so that once we start our clinical testing, we know that there are no confounders at play here. As you can see, I have a checklist here. This is something we use for our hospital. You may want to look at your own hospital's guidelines and regional guidelines and make one for yourself. I think this is really helpful to look at. Number one is the cause of brain injury being known. what caused this event. It's important to note that if you have hypoxic ischemic injury following cardiopulmonary arrest, we really want to wait greater than 24 hours before doing testing. If you are doing ICP management and have given some sort of intervention, generally want to wait 24 hours after the last intervention to do brain death testing. We also want to make sure our brain death injury is irreversible. We also want to look at, is there damage to both the cerebrum and brainstem? Now, it's important to note that the World Brain Death Project guidelines do recognize that there are many regions or countries who may recognize brainstem death. Now, the goal of the guidelines is to get rid of these definitions of whole brain death or brainstem death and kind of just state death by neurologic criteria or brain death. Now, in recognizing that, we do recognize that some states or regions will only need to have injury to the brainstem. It is recognized that if this is a requirement in your region and you are looking at a patient who just has brainstem injury, it is recommended that ancillary testing is acquired to ensure there is not perfusion to the rest of the brain. Also, it is noted that you do not have to have, when we talk about whole brain death, that it is not a requirement that your patient have hormonal abnormalities such as diabetes insipidus. That is actually stated quite explicitly within the World Brain Death Project that is not a requirement to diagnose death by neurologic criteria. The next thing we want to do is make sure confounders are ruled out. So if a tox screen is necessary, do blood or urine tox. If your patient came in and was intoxicated, to ensure that their alcohol level is less than or equal to 80 milligrams per deciliter. The other thing we want to make sure is not confounding is hypothermia. So our patient's body temperature needs to be above 36. Most notably, high temperatures are not an exclusion. We also want to make sure there's enough perfusion to be able to get to the brain should that be possible. So a systolic blood pressure greater than 100 and then a mean arterial pressure greater than 60. You'll notice in my checklist that the MAP is greater than 70, and that's because of a different guideline criteria in the AAN or American Association of Neurology criteria, which my checklist is made from.
When we're looking at death by neurologic criteria, one thing that can confound the exam is metabolic derangements. The World Brain Death Project does not specify specific metabolic abnormalities, but this chart is used within the AAN or American Association of Neurology brain death criteria guidelines, and I find it very useful. So I decided to include it here to give some guidance as to what sort of metabolic derangements may confound our exam. So these are tests you may want to check beforehand. Generally in my patients, if I don't have a reason to believe there should be some sort of thyroid abnormality, this is not something that I'm going to check, but most of the other ones are pretty routine labs that we get. And so making sure that we don't have severe derangement in our ammonia and that our acid-base status is normal. This is kind of a new suggestion to the most updated AAN guidelines that came out around the same time as the World Brain Death criteria, so I think is a good adjunct here.
The next thing you really want to go over is to make sure that all of your drugs have cleared and are not going to confound your exam. Now, these are a bunch of guidelines that are within the AAN guidelines. Again, they're very small, but you want to make sure that 5 half-lives of medications have passed, and you really need to account for both renal and hepatic clearance that may be altered in certain states. So someone with acute kidney injury or acute liver injury, the timelines for clearance of medication may be altered, and so you really want to take those things into account. And in really complex situations, making sure that you're getting your pharmacist involved to help you with those clearances.
To review the World Brain Death criteria, we must establish a neurologic diagnosis that can lead to the complete and irreversible loss of all brain function. It is recommended that the persistence of hormonal regulation function does not preclude the diagnosis of brain death or death by neurologic criteria. We want to make sure that there are conditions or medications, which we just reviewed, that do not confound the exam. And looking at the clinical exam that demonstrates coma, brainstem areflexia, and the loss of inability to breathe independently.
This next slide provides a brief overview of what we're going to look for on our exam.
For brain death or death by neurologic criteria, The World Brain Death Project recommends a single examiner is sufficient, but does state that 2 exams is also acceptable. If there are 2 exams, it is recommended that there not need to be any time between the 2 exams. It's really important to review your own hospital's policy. I currently work at 2 different hospitals that have 2 different policies. In one hospital, a single exam is okay. In the other hospital, there are 2 exams that do not need to be separated by time, but cannot be done within the same room as one another. We want to make sure, as we talked about before, that our vital signs have a temperature above 36 degrees. Generally would be recommended to be using an internal temperature source, such as a Foley catheter or an esophageal probe, and not using oral or axillary temperatures. This can be less reliable. And then to make sure our systolic is above 100 and MAP is above 60. Again, we've talked about we want to avoid confounders, but if those confounders cannot be avoided, if metabolic abnormalities cannot be fixed, or if a patient has a spinal reflex that is not something typical like triple flexion, or if possibly your patient has cervical instability and parts of the exam cannot be concluded, cannot be performed, then we recommend doing an ancillary study. There are also parts of these guidelines that we won't talk about, such as pediatric patients or targeted temperature management. Those can be reviewed in the guidelines.
The next thing we're going to do is talk about the bedside exam, which is the most important part of the entire exam. So first we're going to look for our comatose state. So we're going to give several forms of noxious stimuli. First is going to be an auditory stimulation. We're going to want you to yell the name. Make sure that you're giving enough volume so that even a patient who's in a hearing impaired state can hear you. I use a Q-tip to stimulate deep in the nares. It's a very noxious stimulation internally. We're then, as a part of this noxious evaluation, as well as our motor response, going to give pressure to the temporomandibular joint, the supraorbital notch, as well as the sternal notch. Want to make sure we're giving stimulation above and below the cervical cord in case there's an unrecognized cervical injury. We're also going to give pain in all 4 limbs, both proximally and distally. When I do this, I generally want to make sure that all 4 limbs are uncovered in case you're giving stimulation in one place and you're seeing a reaction in another. If you are unable to do part of these tests, you're going to replace it with an ancillary test, okay? Then we're going to go through our cranial nerves. So checking the pupillary response with a light in each eye and checking a corneal reflex with taking a cotton swab over the cornea. Now, of note, if you have a patient who lacks an eye or who has surgical pupils, you're going to, again, need to use that ancillary test. Also, the next test is the oculocephalic test, where we're going to hold the head in place with the eyes open, making sure our endotracheal tube is secured, and rock the head back and forth, looking for those eye movements. If for any reason, such as cervical instability, you cannot do this test, the guidelines do state that you can replace this with the oculovestibular test. Though we do recommend if both tests can be done, we want to complete both of these. We'll talk more about the oculovestibular reflex in the next slide. You're going to check the cough by taking your suction catheter down your endotracheal tube to check for cough reflex. I generally repeat this twice, just in case there's a patient who has a delayed cough response. And then we're going to check for the gag reflex. Please check both sides of the palate to ensure you're checking both cranial nerves.
Just to briefly review cold caloric testing, we're going to take 30 cc's or more of ice cold water. Generally, I take a large basin, put ice water and water in, and then draw up my 30 cc's. You're going to instill this within the auditory canal, and you're going to have someone hold the eyes open for at least 60 seconds to look for this response. In death by neurologic criteria, you're going to note there is no movement of the eyes when you do this. Importantly, I generally try to start my test with this on one side and then end it with it on the other side because it's important to wait 5 minutes to allow temperature equilibration in between each test when testing both sides of the brainstem.
So the next thing we're going to talk about is spinal reflexes. So when brain death occurs, this can lead to disinhibition of spinal cord reflexes that are normally suppressed. And so usually what we see is the most typical spinal reflex is a triple flexion response. And this is when we give stimulation to generally the lower leg, and we see a flexion at the hip, knee, and ankle. And every time you stimulate, you'll see kind of this same thing happen again and again. Now, if you continue to hold pressure during this reflex, what you'll see is that the leg will relax into the stimulation. If this were a true withdrawal, what you'll see is that the leg would continue to pull back and would not relax into this. And so that kind of proves to you that this is a triple flexion response. Now, generally with triple flexion, because this is such a common reflex, we generally do not recommend ancillary testing in this state. But if you have other reflexes, such as some of the ones listed here, like the Lazarus sign where the patient has kind of like arm elevation and sits up. This is a less typical reflex, and so therefore I would recommend that you get ancillary testing. If there's any sort of movement that you think might be a reflex but you're not sure, I would go ahead and just get ancillary testing to go along with your studies to complete the tests. If you have any question about any of these signs, there are videos online of pretty much all of these reflexes. So I encourage you to go look and see what these look like so you can see if something you're seeing might be that reflex. The next thing, so apnea testing is recommended in every patient case of death by neurologic criteria. Now, if it can't be done, so in some cases, maybe a patient is too medically unstable. Now, patients that I feel this way on, patients on high dose pressors, patients with high ventilator settings, I may, before even doing apnea testing, say this patient's too unstable to undergo apnea testing, and therefore we're going to get an ancillary test. Now, this isn't the vast majority of patients. This is very infrequent. And so in cases where that don't meet that criteria, where you can do this, we're going to talk about how you do apnea testing. So the guidelines state that you need to have a pH of 7.35 to 7.45 at the beginning of apnea testing. Now, you'll note that that's different than the pH we need to have to undergo our physical exam testing, which is 7.3 to 7.5. So this is a little more rigorous because we're talking about that rise in CO2. We also want to see our CO2 be between 35 and 45. And so what we're going to do is we're going to pre-oxygenate our patient on 100% oxygen for more than 10 minutes. I generally then send a blood gas like right before I'm going to do the apnea testing so that I see my CO2's in the range, my pH is in the range, and I have a really high oxygen. We're then going to disconnect the ventilator, and you're going to have your respiratory therapist or yourself or your nurse take an oxygen catheter and put it down the endotracheal tube. And you're going to put no more than 6 liters per minute down the carina for passive oxygen infiltration. If at any point during your test you see that your oxygen saturations are dropping below 85%, you're going to want to just abort the test. Do draw an ABG at that time, but we are going to want to abort the test at that time. So while your patient's off of the ventilator, I generally take the entire gown off to watch the whole chest and look for a rise of the chest to see if our patient is breathing. We are going to check multiple ABGs over this time period. I generally check a ABG at 6 minutes, 10 minutes, and 12 minutes if your patient is stable and can undergo that amount of time. Now, generally, to declare death by neurologic criteria, your PCO2 needs to rise above 60 or greater than 20 points from whatever the baseline was. So if they're at 45, they need to be at 65. And then the new guidelines state that your pH actually has to be less than 7.3 with this as well. And then just to state, I have had different instances where I have had to repeat apnea testing because at the 12 minutes they had not met that mark and we had to actually go longer. That is probably very few cases in my entire career, but just something to keep in mind. If you are still seeing that rise, you may just need a longer period of time if you're not reaching that goal. Now I'm going to go over ancillary testing. So ancillary testing helps when the clinical exam has confounders. So as we talked about, if you're unable to do apnea testing, you need an ancillary test. Let's say a patient has eye trauma or cervical trauma that prevents part of the clinical exam, you're going to need an ancillary test. Or a patient has even just a surgical pupil that is not reactive due to previous eye surgery. That patient would require an ancillary test. Patients with high cervical injuries who maybe don't have a CAG or a cough, these patients would also need an ancillary test. Anything that we can't resolve. So let's say you have a metabolic abnormality that we can't resolve with dialysis, or we can't seem to get the ammonia less than 75. Again, you're going to want an ancillary test. So of note, most importantly, the EEG is no longer considered an ancillary test. I think the importance of this is that EEG was really just looking at cortical reactivity and does not test the brainstem, which is really why it was taken off of the guidelines. So currently there are 3 and this is for adults over the age of 18, nuclear medicine cerebral blood flow study and digital subtraction angiography, along with transcranial Dopplers, are approved for adults over the age of 18. Now, if you have a pediatric population, again, those are kind of, while included within the guidelines written, pediatric patients are not approved for transcranial Dopplers, but the other 2 studies would be appropriate ancillary tests. So digital subtraction angiography is the gold standard test. It's lack of cerebral flow on a 4-vessel angiogram. As you can see, on the left, we have a normal cerebral angiogram. On the right, we have a patient with no intracranial flow. You cannot get a CT angiogram or an MR angiogram to qualify for brain death here. The next is nuclear medicine cerebral blood flow. This is giving a nuclear tracer, and we're looking for lack of that tracer intracranially. As you can see, this is called like the empty light bulb, and we see this brain without that dark tracer in the brain, and that would be consistent with death by neurologic criteria.
With transcranial Dopplers, we're looking for biphasic oscillating flow and systolic spikes with reversal of flow in diastole. It's important to note that 10% of patients will have no acoustic windows, and therefore transcranial Dopplers will not be able to be obtained. It's also noted that in the World Brain Death Project criteria, they do recommend that 2 sets of TCDs be obtained. And when they say 2 sets, they mean 1 set before cerebral circulatory arrest so that you can see what the patient's normal blood flow is. And this is due to this 10% lacking these windows. And then 1 set afterwards so you can see that there has been a change in flow.
So one of the questions that's always asked is, when is the time of death? So apnea testing should be performed at the end of the clinical exam. Ancillary testing should be performed at the very end. So if you do apnea testing, the time of death is when the CO2 is recorded in the chart as being above 60 or less than, with a pH of less than 3. That will be your time of death. And if ancillary testing is used, it will be the time that the report is marked in the medical record as being reported by whomever is reading it. That will be the time of death. And that really concludes my talk on death by neurologic criteria. Please feel free to reach out. Email me at jacqueline.kraft@emory.edu if there are any questions that I can answer. I'd be happy to answer them.